Welcome to the Hospital Medicine Unplugged podcast. Today, we are undertaking a really critical deep dives into one of the most persistent and, frankly, frustrating issues we all face on the acute care wards. We're talking about the systematic management of behavioral and psychological symptoms of dementia, which we all know as BPSD. And this isn't just a common complaint, it's a profound clinical challenge. When we're talking about BPSD, we're talking about those non-cognitive symptoms of neurodegeneration. Things like agitation, aggression, psychosis, sleep disturbances. And these occur in well over 90% of individuals with dementia at some point in their illness. In the hospital, BPSD really becomes the axis around which the entire admission rotates. These behaviors are often the reason for the hospitalization in the first place. And maybe more critically, they profoundly complicate our ability to deliver even standard medical care. Things like giving antibiotics or just monitoring fluids. So what we need is a rigorous, structured, and evidence-based way to navigate this. And building that structure is really the mission of this deep dive.
I think we have to start by understanding the immense stakes involved here, because BPSD it's far from a minor inconvenience. It's a really broad and challenging umbrella. It covers a huge spectrum. Agitation, physical aggression, various forms of psychosis.
Like delusions and hallucinations.
Exactly. And also apathy, depression, anxiety, severe disinhibition, and these pervasive sleep disturbances. And what's fascinating here is that this whole spectrum of behaviors is inherently linked to fundamental adverse outcomes.
So it's not just a symptom, it's a prognostic indicator.
Precisely. Clinically, BPSD is associated with faster overall disease progression. And crucially, it predicts significantly greater morbidity and mortality. When you really analyze the data, the presence of these symptoms is associated with a nearly doubled mortality risk. We're talking an odds ratio of about 1.90 in major cohorts.
Doubled mortality risk. That statistic is staggering. It really demands a moment of reflection.
It does.
It suggests that the symptoms we categorize as behavioral are in fact physical safety events that we are currently failing to adequately control or prevent.
Absolutely. The morbidity is driven by those immediate risks, falls and inability to participate in rehab, self-extubation, pulling lines. But the long-term societal and systemic costs are also just enormous. BPSD is a major driver of increased healthcare burden. It leads to higher rates of nursing home placement just because caregivers can't cope. And it accounts for a staggering 1/3 of all dementia care costs globally. So if we can manage BPSD effectively, we are achieving a major public health victory.
Okay, so before we get into management algorithms, we should probably frame the major dementia subtypes, right? Because their behavioral fingerprints are critically different.
Certainly. A working differential is essential. We often deal with Alzheimer's disease, AD, where behavioral changes generally start later. They're often dominated by apathy, maybe some wandering, occasionally psychosis.
And then there's vascular dementia.
Right, vascular dementia. Characterized by deficits in executive function, that stepwise decline. And there, depression and emotional lability can be really prominent. But there are two subtypes that demand intense vigilance when it comes to BPSD management.
Okay. First, we have Lewy body dementia. This is crucial because it presents with cognitive fluctuations, extremely vivid visual hallucinations, and spontaneous Parkinsonian features. The Lewy body patient is just behaviorally distinct.
And a second.
Second, frontotemporal dementia, or FTD. It's defined by those early and pervasive personality and behavioral disturbances. In the behavioral variant, severe disinhibition and impulsivity are the key features.
So understanding these differences is paramount because it dictates your therapeutic choices, and especially what's contraindicated.
Exactly. Our mission today is to move beyond these generic agitation protocols and deliver a structured, evidence-based, and subtype-aware approach for the acute hospitalization.
Okay, let's unpack this. Before we react to a behavioral crisis, the first step has to be a root cause analysis. We need to identify both the immutable factors, the neurobiology, and the acute, often reversible hospital triggers that are pushing the patient over the edge. The underlying neurobiology is truly the foundation of the problem. BPSD is a direct manifestation of this complex neurotransmitter dysregulation from the neurodegeneration. The most consistently recognized and actionable deficit is cholinergic dysfunction. This deficiency of acetylcholine seems to play a major role in BPSD.
And that deficit provides the rationale for a major drug class we use.
Precisely. The efficacy of cholinesterase inhibitors in controlling BPSD symptoms, independent of their modest cognitive effects, provides high-level evidence for this link. If you know the patient's overall cognitive stability, their ability to tolerate stress, is compromised by this cholinergic deficit, then your foundational management has to include maximizing that stability.
Which means continuing or optimizing those cognitive medications.
Exactly. Don't stop them on admission. And beyond the cholinergic system, specific symptom clusters map to other neurotransmitter systems. For instance, psychosis and dementia, delusions of theft, paranoia, is highly correlated with dopaminergic changes. Specifically, increased D3 receptor density in the nucleus accumbens and greater D2-D3 receptor activity. This explains why we use dopamine antagonists, antipsychotics, but also why a dopamine-sensitive disease like Lewy body dementia reacts so catastrophically to them.
And for agitation, that's the most common thing we see acutely.
Agitation and aggression often involve a serotonergic imbalance. Polymorphisms of the 5-HT2A receptor gene are consistently associated with these outwardly directed behaviors. So structurally, the patient is dealing with a fundamental impairment in their central inhibitory systems.
And anatomically, where does this vulnerability live in the brain?
The anatomical correlation points strongly to frontal lobe dysfunction, specifically the anterior cingulate cortex, the ACC, which is critical for filtering stimuli, and the orbitofrontal cortex, or OFC, which governs decision-making. So when a hospitalized patient with dementia reacts with global arousal, screaming, fighting in response to something minor like a paging speaker, it's often because those ACC and OFC filters are just non-functional. The brain's executive filter is broken.
That makes the patient incredibly vulnerable to the hospital environment, which is, inherently chaotic and overstimulating. Let's shift our focus to the acute hospital triggers, the part we can and must investigate and reverse.
That vulnerability aligns perfectly with what's called the progressively lowered stress threshold model. Essentially, the cognitive impairment means the patient has a diminished capacity to receive, process, and respond to environmental stimuli. The bar for tolerance is just incredibly low.
A sudden noise, an unfamiliar face.
Any of these can instantly push them into a state of crisis.
And the medical derangements that act as immediate precipitants. We have to be aggressive in seeking those out.
They are numerous, and failing to find them is, you could argue, medical malpractice in this population. Delirium is the single strongest acute link. We know 60% of hospitalized patients with dementia have a superimposed delirium at admission.
60%.
It's a huge number. So we have to systematically investigate for acute infection, UTIs, pneumonia, as well as those easily missed things like constipation, urinary retention, or metabolic derangements like hypothyroidism.
I often find the single most overlooked factor that drives intense suffering and behavioral response is pain.
It's a crucial point. It's why it requires specific attention in our assessment. The unrecognized pain factor is a massive contributor to agitation, but it's notoriously difficult to recognize because of sensory confusion and communication deficits. We systematically underestimate how painful an underlying medical condition is, or even just the discomfort of prolonged immobility or an IV site. The patient can't verbalize it, so the pain manifests as aggression or agitation.
Then we arrive at the iatrogenic factors, the harm that we as the care team inadvertently introduce.
Iatrogenic factors, especially polypharmacy, are pervasive. Data shows 77% of patients have polypharmacy on admission, and the med count usually increases during the stay. The high-risk meds are the ones that aggravate BPSD or cause delirium. We have to look aggressively at anticholinergics, which are often hidden in common over-the-counter meds. We can quantify this risk using the Drug Burden Index, or DBI. Data shows a DBI greater than 0 is present in 53% of patients on admission, and higher DBI scores translate directly to increased risks of falls and delirium.
So if we're prioritizing intervention, medication cleanup is the first therapeutic act, even before thinking about adding a new psychoactive drug.
Absolutely. We must perform aggressive deprescribing. The Beers criteria clearly identify benzodiazepines as high risk, causing paradoxical agitation. But we also have to be wary of seemingly benign agents. Even common SSRIs, like sertraline, can cause subtle but profound adverse effects.
Like GI distress or
critically, akathisia.
Let's pause on akathisia. For a peer audience, how do we differentiate that drug-induced restlessness from typical dementia agitation, especially when the patient can't tell us, my legs feel restless?
That is where clinical skill is paramount. True akathisia is a severe subjective distress from motor restlessness. It manifests differently. Dementia agitation often has an external trigger, a noise, a demand. Akathisia is a pervasive internal need to move. The patient will often rock, pace incessantly or fidget continuously, even when the environment is calm. The key is that the motor restlessness is not goal-directed. It's compelled by an internal drive. Recognizing it means stopping the offending agent immediately. And this raises an important question. Given this complexity, from neurobiology to polypharmacy, how do we, in a busy ward environment, systematically capture the behavior and, most urgently, differentiate it from acute, superimposed delirium?
The sources strongly emphasize that we have to move beyond just charting patient is agitated and adopt a structured approach. That approach starts with the DICE framework. It's an invaluable acronym. Describe the specific behavior, investigate the underlying causes, create an individualized intervention, and evaluate its effectiveness. It forces a root cause analysis before you act.
And that investigate step always hinges on separating chronic BPSD from acute delirium. The time course is the key. Delirium is acute or subacute, developing over hours to days. Chronic BPSD has a baseline over weeks or months. But the most critical differentiating feature of delirium is that fluctuating deficit in attention and level of consciousness.
Which validated tools should we be relying on for this in the acute setting?
We have to use validated tools. The Confusion Assessment Method, or CAM, is the gold standard for diagnosis. It requires acute onset, inattention, and either disorganized thinking or an altered level of consciousness. It's highly specific at 0.98. If a patient is CAM positive, they almost certainly have delirium.
And for rapid screening?
For rapid screening, the brief high-sensitivity 4AT is very practical. Its sensitivity is very high, around 89.7%, making it an excellent tool to screen everyone on admission.
And getting that collateral history is key.
Oh, it's absolutely vital. Failing to get history from an informant family nursing home staff is the leading reason for misdiagnoses.
Okay, so once we identify the behavior, quantification is necessary. How do we move from a subjective description to objective metrics that let us track response? We need something that tells us if our intervention is actually moving the needle.
Exactly. Behavioral quantification tools help us do that. Things like the Neuropsychiatric Inventory, or NPI, which measures frequency and severity of 12 behaviors, or the Cohen-Mansfield Agitation Inventory, the CMAI, which focuses on agitation. They allow us to establish a clear baseline and track our response. This is really important because we have established benchmarks. Agitation instruments have a minimal clinically important difference, an MCID of meta 5 points. If you don't hit that target, the intervention is likely not worth the risk.
Let's circle back to that silent trigger.
Yeah.
Pain. Since these patients can't communicate it effectively, structured assessment is vital.
Yes, since pain is so common and so often missed, we must use an observational assessment. The PAINAD scale pain assessment in advanced dementia is critical here. It scores 5 domains from 0 to 2 for a total of 10. And these domains are observable even in a nonverbal patient. Breathing, negative vocalization, facial expression, body language, and consolability. A high score on PAINAD flags pain as a likely trigger, guiding us toward a stepped analgesic approach. We treat the pain, and the reduction in agitation is the secondary proof that we were right.
So following the DICE framework, the investigate phase concludes with that crucial medication review, the cleanup step.
Yes, medication review and deprescribing are mandatory steps before ever considering adding a new psychotropic. We have to review every single medication, quantify the anticholinergic burden with the DBI, check for high-risk combinations, opioids, benzodiazepines.
And continue the cognitive meds.
Critically, yes, we must continue the cholinesterase inhibitors, donepezil, galantamine, and memantine. The cleanup is about subtraction of harm, not general discontinuation of everything.
Here's where it gets really interesting. The consensus guidelines from the AGS, the APA, all major bodies, mandate non-pharmacological approaches as the absolute first-line treatment. And this represents the biggest operational challenge in acute hospital care.
It is the operational challenge, but it is supported by the data and the safety profile. Pharmacotherapy is often sought as the fastest solution, but the evidence is clear. Non-pharmacological strategies should be attempted before and sustained alongside any pharmacology.
So let's focus on the strategies with the highest quality evidence. Where do we get the best bang for our buck?
The power of caregiver involvement stands out as having the most consistent evidence base. Caregiver-focused interventions, which are, not just counseling, but actual skills training and psychoeducation, significantly reduce BPSD frequency and severity. And crucially, these interventions also mitigate caregiver distress, which we know is the #1 precipitant for institutionalization.
In the acute hospital setting, though, we often lack the consistent staffing or trained volunteers for that. How do we implement this philosophy on a busy medical floor?
We have to rely on structured, multi-component interventions. The AGS Co-Care, HLLP program, the Hospital Elder Life Program, is the gold standard for delirium prevention, which is, as we've said, inextricably linked to BPSD. HELP integrates 6 core elements: reorientation, strict sleep hygiene protocols, early mobilization, sensory optimization, making sure they have their glasses and hearing aids, and adequate hydration.
That seems like a huge resource lift. We need to frame this for our peers not as an expense, but as a mandatory quality initiative.
It is exactly that. And the data justifies the effort. These programs demonstrably reduce delirium incidence by a remarkable 43% compared to usual care, and that translates to a reduction in hospital length of stay by about 1.3 days.
Moving to specific symptom-targeted strategies, what sensory and functional approaches work best for acute agitation and aggression?
For agitation and aggression, the evidence is strong for tailored sensory interventions. Massage and gentle touch therapy show surprisingly high efficacy, with a large standardized mean difference of -0.75.
Really? That high?
Yes. It likely works by just reducing arousal and providing non-threatening human contact. Music therapy is also highly beneficial, with an SMD of natting 0.49, especially using personalized playlists from the patient's younger years. The key takeaway, though, is personalization. Personalized activities that cater to the patient's residual abilities and interests are consistently more effective than standardized generic activities. This is the essence of person-centered care.
And when a patient is confused, expressing a distress that we know is rooted in a distorted reality like believing they're being held captive, how do we respond effectively?
We strongly advocate for validation therapy. The natural instinct is to reorient, no, you're in the hospital. But confrontation often escalates distress. Validation therapy means acknowledging the patient's underlying feeling or perceived reality. I understand you're feeling scared, rather than arguing about the facts.
And pair that with reminiscence therapy.
Exactly. Use those early memories that are often the most preserved. Engaging a patient about their childhood or career can be a powerful way to redirect and connect.
Finally, the environmental and safety aspect. We often create the problem with our own environment. What are the key environmental fixes?
The environment needs careful management. We need consistent staffing, especially at night. And we must minimize physical restraints at all costs. They are associated with increased agitation, functional decline, and injury. The moment a patient is physically restrained, agitation often escalates because they feel trapped. We have to aggressively avoid unnecessary lines, monitors, or indwelling catheters that increase physical tethering and iatrogenic risk. So now, if we've exhausted all of those non-pharmacological options and the patient poses a severe risk of harm, we have to discuss pharmacotherapy. But this is reserved for severe or refractory symptoms, and it must adhere to strict principles.
The first principle is paramount, given the extreme vulnerability of this population.
It is the principle of using the lowest effective dose for the shortest duration. In the acute setting, we're talking hours to days, targeting crisis resolution, not long-term stabilization. And the decision to start high-risk medications, especially antipsychotics, must be documented, with risks and benefits clearly discussed with surrogate decision-makers.
And as we said before, continuing baseline cognitive agents remains crucial.
Absolutely. Continue the donepezil, the galantamine, the memantine. They have high-quality evidence for BPSD overall and provide a foundational stability we shouldn't remove.
Let's look at the cornerstone of acute management, antipsychotics. We know they're widely used, but the efficacy data is consistently modest, especially when weighed against the severe risks.
The efficacy is indeed modest. We're talking a standardized mean difference of only -0.13. To put that in perspective, the effect size is small. And furthermore, clinical trials show no clear superiority of one atypical agent over another.
So they shouldn't be the go-to for mild agitation.
Absolutely not. They should be reserved solely for severe symptoms or when the patient poses a documented significant risk of harm.
There have been some recent developments here, though, with the FDA.
Yes, brexpiprazole is the newest agent to receive FDA approval specifically for AD agitation, often at 2 to 3 milligrams per day. However, any enthusiasm for a new agent has to be tempered by the severe safety crisis that affects the entire class of atypical antipsychotics.
And we have to drill down on those class risks because they're so consequential.
The risks are substantial. There's an FDA black box warning for increased mortality risk, often from sudden cardiac death or pneumonia. They also increase the risk of cerebrovascular events
And cognitive decline.
and cognitive decline, plus extrapyramidal symptoms, or EPS. Atypical antipsychotics are associated with a mild but detectable functional decline in the first few weeks after you start them.
So if the risk-benefit for antipsychotics is so unfavorable, what role do other agents like antidepressants play?
Well, for primary agitation, the evidence is very specific. Citalopram showed small positive effects in the CITID trial. However, we have to stick to dosing limits. Use above 20 milligrams per day is concerning in older patients because of the risk of QTC prolongation.
Which means baseline and repeat EKG monitoring.
Correct, which adds complexity.
And what about other popular agents we reach for, like for sleep?
We have crucial negative evidence here. Mirtazapine is ineffective for agitation, as shown definitively by the Seneng-B trial. Clinicians often substitute it for an antipsychotic to avoid the black box warning, but it's a strategy that lacks efficacy.
But trazodone.
Trazodone, conversely, has the most persuasive evidence specifically for improving sleep disturbances, which is often a primary trigger for behavioral problems.
And anticonvulsants. Mood stabilizers.
Anticonvulsants like valproate and carbamazepine are generally discouraged. There's a consistent lack of evidence of efficacy for agitation, and they carry their own risks of sedation and toxicity.
Okay, we have to move to the critical area of subtype-specific cautions. Mismanaging patients based on generic protocols can have disastrous consequences.
This is non-negotiable, particularly for Lewy body dementia or LBD. These patients have an extreme hypersensitivity to all dopamine-blocking agents. Up to 50% can have severe, potentially life-threatening reactions.
So typical neuroleptics are strictly contraindicated.
Strictly contraindicated.
So if they are prone to psychosis, what is the preferred approach for LBD?
Given their dopamine sensitivity, cholinesterase inhibitors are the preferred pharmacological approach for neuropsychiatric symptoms in LBD. They offer the best risk-benefit profile. If psychosis is refractory and severe, pimavanserin may be considered. It has a unique mechanism that avoids the dopamine antagonism that causes those severe reactions.
And what about the behaviors in frontotemporal dementia, FTD, specifically that severe disinhibition?
FTD is characterized by severe disinhibition, impulsivity, repetitive behaviors. Here, the neurobiology is different. For these core behaviors, the preferred agents are SSRIs, targeting the serotonergic dysfunction. Sertraline or citalopram are often the first choice. Antipsychotics have limited evidence in FTD, but if required for severe aggression, a low-potency, atypical agent like cupapine is often recommended clinically, though the evidence base is scarce. So if we connect all this to the bigger picture, preventing DPSD and delirium is critical not just for the patient, but for meeting modern hospital quality metrics.
That structural and preventative focus starts with incorporating those HELP program components into standard 247 practice.
Absolutely. The components that most strongly reduce delirium risk are aggressive reorientation, cognitive stimulation, and rigorous sleep hygiene. And beyond that structure, we need an intense focus on mobility. That means actively decreasing immobilization equipment, indwelling catheters, IV lines, monitors. Every tube and line increases agitation. And for pain, we need scheduled pain management, not PRN, to prevent pain from spiking into a behavioral crisis.
These prevention bundles are effective during the stay, but the discharge process is where this fragile plan often collapses. This transition is a profoundly vulnerable period.
Discharge planning is a massive failure point. The data on information omission at discharge is shocking. For anxiety management strategies, the omission rate was found to be 94%. For aggression management techniques, 77% of critical information was omitted from the summary.
That's an indictment of our transitional care process. We identify that music therapy works, but that information never leaves the unit.
Exactly. And the irony is that medication changes, particularly starting a high-risk medication like an antipsychotic, are communicated more reliably. The omission rate there is only 12.9%. We effectively communicate the risk, but we fail to communicate the safety solutions.
Which emphasizes the absolute necessity of a proactive and structured deprescribing strategy.
The need for deprescribing is urgent. Approximately 1/3 of older adults started on antipsychotics in the hospital continue them post-discharge unnecessarily, prolonging their exposure to long-term risks. We have to make the plan to discontinue before the patient leaves.
So how do we make sure that the non-pharmacological gains, that 77% of omitted information, are communicated and sustained?
We need structured, standardized documentation. I'd recommend using frameworks like the 4 M's is what matters: medication, mentation, mobility. The documentation has to be specific and actionable. It needs to list the BPSD triggers we identified. Was it hunger, pain, noise, and the successful non-pharmacological strategies used? You have to document validation therapy worked best when, or pacing at 4 p.m. was successfully redirected using a sorting task. This personalized plan is what protects the patient and supports the caregiver or post-acute facility.
And finally, for patients with advanced dementia, the conversation has to focus on global goals and comfort.
For patients with advanced dementia, goals of care discussions and palliative consultation are crucial. Management must focus squarely on comfort, symptom control, and dignity. This often means avoiding burdensome interventions and aligning our acute management with a compassionate approach to their overall trajectory.
So what does this all mean? The way we manage BPSD in the hospital has massive, long-term implications that define their functional capacity moving forward.
The outcomes data clearly shows that managing BPSD effectively is a critical patient safety concern. The presence of BPSD in the hospital significantly predicts poor long-term outcomes. These patients are 41% less likely to discharge home. That's an odds ratio of 0.59.
Wow, a 41% reduced chance of going home. That statistic alone should redefine how we prioritize BPSD management. What about quality metrics during the stay?
The impact is profound. We see a significant increase in physical restraint use in 22% of these admissions. And these patients experience a higher use of uncomfortable interventions, like indwelling bladder catheters.
And the risk profile we discussed for pharmacology comes home to roost here, linking our treatment choices to those poor outcomes.
It does. Effective BPSD management is vital for improving quality by reducing unnecessary, prolonged antipsychotic exposure. The fact that hospital mortality is nearly doubled, that odds ratio of 1.90 underscores the lethal interplay between acute illness, neurodegeneration, and iatrogenic risk. So the systematic approach, starting with DACE, prioritizing non-pharmacological interventions, performing aggressive medication cleanup, and adhering rigorously to subtype-specific cautions like for Lewy body dementia, this is not just about acute symptom relief. It is a fundamental leverage point to reduce long-term institutionalization risk and improve the functional and cognitive trajectory of our most vulnerable hospitalized patients. Given that BPSD is a fundamental and often accelerating aspect of neurodegeneration that directly affects disposition, how might we better integrate structured long-term caregiver support and psychoeducation into our acute hospital setting to ensure the gains made during hospitalization are effectively sustained and translated to the home or post-acute environment?